Hi guys, welcome back to the channel. Today we are discussing classic trial restricting the volumes of resuscitation fluid in adult with a septic shock after initial management.
Disclaimer: the content and information on this video is for education purpose only and is not intended to be recommendation of any kind of some whatever. Under any circumstances, the author accept no liable for any indirect, incidental, consequential, exemplary damages arises. This video may contain copyright material, the use of which may not have been specifically authorized by copyright owner. This video is available in an effort to advance understanding of educational content.
Clinical question for this study: in ICU patient with septic shock who have had an initial fluid resuscitation, what are the effects and feasibility of protocol restricting to the further resuscitation fluid as opposed to the standard care? The classic trial, the restrictive versus standard fluid. Design for this study: this is open label, multi-center, stratified parallel group, clinical trial, clinicians and patients not blinded, computer generated allocation sequence with the permitted blocks of 2 and 4, web-based centralized randomization system with a stratification by site, 1:1 randomization to restrictive protocol or standard care, intention to treat analysis, several statistical analysis performed, primary outcome compared using the mixed pragmatic general linear mode or non-pragmatic Van Iltron methods, adjust for site randomization, logistic regression, log rank or Cox used for the secondary outcome measure, primary outcome reanalyze with the second model adjusting for certain predefined baseline risk factor. Modification of primary outcome occur 1 month before trial ended with the promotion of secondary outcome. 2 co-primary 1 power calculation: 150 patient needed to show 1.7 difference in a volume resuscitation fluid within the first 5 days based on 6S trial data at a power of 80 and 2 side alpha 5%. Setting for the study: 9 general ICU in Europe, Denmark and Finland. Duration for the study: September 2014, August 2015, almost 1 year. Population for the study: inclusion criteria: age may be must 18 year more, sepsis defined by the SCCM or ACCP guidelines 2008, 2 out of 4 SRS criteria, and suspected or confirmed site of infection, positive blood culture. Suspected or confirmed circulatory impairment: at least 1 systolic BP less than 90, lactate more than 4, heart rate more than 140, use of vasopressor, at least 30 ml per kg ideal body weight fluids, crystal colloid and blood given within the last 6 hours. Shock defined as ongoing infusion of norepinephrine, we call NORAD, to maintain a blood pressure. Exclusion criteria: use of any form of or RRT deemed imminent by ICU physician, several hyperkalemia within the last 6 hours, creatinine more than 350 micromoles per liter, invasively ventilated with FiO2 more than 0.08 and PEEP more than 10, life-threatening bleeding, kidney or liver transplantation during the current admission, burn more than 10%, previously enrolled in classic trial, patient with treatment with limitation, not a mechanical ventilation or RRT, concern unavailable, total 203 patients screened, 153 randomized and 150 in final analysis. Intervention for this study: fluid restriction group, isotonic crystalline fluid boluses 250 to 500 ml, IV allowed during the ICU stay for severe hypoperfusion defined by lactate more than 4, MAP less than 50 despite non-epinephrine infusion, mottling score more than 2, oliguria less than 0.1 ml per kg ideal body weight in last 1 hour. Control for standard care group: isotonic crystalline boluses allowed during the ICU stay as long as hemodynamical variable improved during the dynamic or static measure of fluid responsiveness, whichever the clinician choice. In both management common in both group. MAP more than 65 mmHg or targeted decided by clinician, maintained during the ICU stay. non-epinephrine, first line of vasopressor, choice of crystalloid not specified, colloid seen as a protocol violation, effect of fluid boluses monitored 30 minutes after intervention, concomitant treatment for sepsis, other vasopressor, inotrope, glucocorticoids, blood products, RRT, intervention for AF, provided base of surviving sepsis guidelines 2012. Overt fluid losses, bleeding, diarrhea, ascites, pleural effusion allowed to the substituted. Electrolytes water supplement recommended entirely. IV isotonic glucose allowed if total fluid input less than 1500 ml. Enter supplementation not possible. Protocol temporarily suspended during the life-threatening bleeding. Outcome: co-primary outcome: amount of resuscitation fluid used in first 5 days and over length of ICU stay post randomization was significantly less in fluid restricted group. First 5 days, fluid restricted group, median 500 ml, site weight mean was 1687 ml. Standard care group, medium 2000 ml fluid, site weight mean 2928 ml. Absolute difference in 1241 ml and p value less than 0.001. During entire ICU stay, fluid restricted group, median 500 ml, site weight mean base 1922, and standard care group, medium 2000 ml, site weight mean 3399 ml. Absolute difference in mean 1407, p value less than 0.001. Secondary outcome: no significant difference in total fluid inputs and cumulative balance during the first 5 days overall the ICU stay. Adverse incidents: no significant difference in adverse reaction to crystalloid, norepinephrine or ischemic events. Exploratory outcomes: death at 90-day, ischemic events, days alive without mechanical ventilation or RRT, maximum changes in plasma creatinine, no significant difference. Worsening of acute kidney injury defined by KIDO score, significantly lower in fluid restriction group. The table describes the pro-primary outcome, secondary outcome and tertiary data. No significant data available or no difference between the primary, secondary outcome and primary outcome in restricted fluid groups and standard care group. Strength for this ICU trial: the important clinical question, especially after the FIST trial, which suggests harm from the large volume fluid resuscitation. Multi-site, multi-country trial, care broadly standardized between the group, clear separation of practice achieved between the groups despite the lack of blinding. Intention to treat analysis: only 2 patients excluded. Lack of blinding leading to the significant weaknesses for this trial. Significant clinician levy over the map target, co-intervention and fluid responsiveness target. While this reflects real world practice, it does not reduce the internal and external validity of the trial data. Adding primary outcome measure just before the trial ended. While this did not affect the actual recorded primary outcome, the trial was not designed to examine this variable. Despite the trial conditions, significant number of protocol violations were observed. 34 patients in the restrictive group and 23 patients in control group. The considerably reduced the impact of intervention, mostly notable. 27 patients in the intervention group received fluid boluses outside indication. 16 restrictive fluid patient and control 18 in control patient received colloids. There was no significant difference in total fluid given to both groups of a patient either during the first 5 days or overall during their ICU stay. The 1 liter deficit in resuscitation fluid seems to have been corrected for elsewhere. NG feeding fluid with medication, the restrictive group may not have been truly restricted after all. Author conclusion: protocol aimed to restricting resuscitation fluid is feasible and result in reduced volume by volumes of resuscitation fluid compared to the protocol aimed at a standard care of ICU patient who had undergone initial resuscitation. This may I suggest this trial demonstrated the feasibility of fluid restrictive strategy post initial resuscitation patient with septic shock. However, truly restrictive strategy seems difficult to implement without protocol violation. The total fluid volume were actually no different between the groups In this trial, this makes safety of this approach difficult to gauge, and strategy of limiting any post resuscitation fluid to patients who are either fluid responsive or tolerant using dynamic indices of fluid responsiveness seems to be supported by this trial and other available data from the FIST and FACT trials. This will be remain my current strategy.